we need a consult, we'll do that through telemedicine, through our other hospitals. If we believe the patient needs to be transferred, then we will transfer him to Tirupati, where there is a medical college. And if the patient requires tertiary care, then we will tell the family that this patient needs to be taken to perhaps Chennai or Bangalore, which is 3 to 5 hours away. And of course, all this is digital. Apollo Digital is our EMR, which meets the standards that the Government of India has set, and we are rolling this out across hospitals. One of our hospitals now is paperless. We have been able to achieve stage 6 in HIMSS, and we are really excited about taking Apollo Digital across the group. EICU, extremely important. How many pediatric or adult intensivists can we find? But there is need for intensive care across the length and breadth of the country, and we should not be held hostage by the lack of skilled manpower needed to man these, because you have EICUs. So we are able to monitor as many as 500 beds from one location manned by a team of intensivists, and we've already tied up with smaller nursing homes and hospitals that have about 4 beds or more of ICUs. We are in the process of tying up with some public sector units, and of course exploring the possibility of a PPP mode for government hospitals. We have a call center that functions 24/7, and that really has made life a lot easier as far as being able to reach out to our patients is concerned. Mr. Clinton had inaugurated our first telemedicine center in Aragonda in 2000. Since then, we've grown considerably. We've done more than 100,000 specialty consults across 25 specialties, and this really is growing, and every month we are seeing more and more traction, because that's really something that the people are getting more and more comfortable with. We are able to do a lot of consults for patients from other countries where they've had procedures done in our facility and then need to come back just to show their blood reports or for very simple alteration in prescriptions, which can easily be done through telemedicine. Teletriage, voice-based teleconsults through our medical response center, quite popular really on whether you need to see a doctor or not. Simple, cost-effective is something that we have used reasonably well. HIPAR is something that we're really excited about. It's the Healthcare India Pharmaceutical Registry. It's really one of the most advanced pharmaceutical databases in the world. The idea really of HIPAR is how is it that we can reduce medication errors. It's been incorporated into EMR. So quite often you have someone who's on 5 different medications that interact with each other. You really need help on what you need to have before a meal, what after a meal, what can be given together and what can't be given together, what is the drug-drug interaction that could be really serious, what is the drug-diet interaction that could really compromise the efficacy of the medication, and HIPAR really has been very useful. SNOMED, as we all know, really surpasses ICD-10. We are in an advanced stage of deployment of SNOMED CT into our EMR systems, and once we are familiar with it and comfortable with it, then we would like to help, if possible, or assist other organizations as they move towards SNOMED. Let me give you a live example on how we've tried to put the pieces together. An individual walks in, he's been diagnosed to be a diabetic. So he comes in, he gets a unique ID number, he gets enrolled into a program which is called Apollo Sugar. He goes through the diagnostics, he's seen by an endocrinologist, he's seen by a podiatrist, he's been seen by an ophthalmologist if needed, a neurologist, a vascular person, a nurse educator, by a dietitian. So all this information is then collated. We also teach the individual how is it that he needs to monitor things when he goes back. So we teach him some basic parameters that he needs to be careful of. We teach him how to actually measure his glucose every day. So all this information then is SMSed by this individual onto the call center, where we have algorithms that can guide the call center executive on, hey, this is what your sugar is today, I'm on so much insulin, what do I need to do? Does my insulin need to go up? Is it fine? Or do I need to taper it down? Or what is it that I need to do to be able to maintain my sugar? So ever since we launched this program, we've been tracking the glycosylated hemoglobin levels, and we've seen that when you enroll into a program which is as active as this, your glycosylated hemoglobin comes down, and that we all know tells us about how your sugars have been in the last 3 months and has an important value in terms of predicting whether you're going to get some of the complications of diabetes. And we know that diabetes is a chronic condition. It produces damage in many organs, and it's really about how you manage your sugar that has an impact on what will happen 10, 20, 30, 40 years down the road. Now, how is it that the clinicians can really partner with hospitals and management in terms of the whole e-health discussion? See, what every clinician is really interested in is outcomes. Patients come to you, you stratify them based on their risk stratification as best as you can, and then you want to give them the right treatment, and you want them to go home, and you want your patients to say, wow, you're such an excellent doctor, and tell the whole world about it. So basically, it's about outcomes. So we've developed Apollo Clinical Excellence, which is ACE at 25. It's a balanced scorecard where we look at 25 parameters which are benchmarks against the world's best published outcomes, and these become available on the Apollo Lighthouse platform. For example, bypass surgery, the best outcomes are from Cleveland, and their inpatient mortality is 0.6%. So if any of our hospitals has a mortality of more than 2%, they get a score of 0 out of 4. But if the survival figures are more than 99.2%, they get a score of 4 and 4. So like this, we have 24 other parameters where we've looked at the world's best published outcomes and benchmark against them. So what we get at the end of each month is a score of 100. The maximum score possible is 100, which is impossible if you do complex work. We want each of our hospitals to be in the green zone, which is anywhere more than 75. If the hospitals go into the orange zone, they have to tell us why they're in the orange zone, and we of course do not want any hospital to be in the red zone, because they go into the red zone, the CEO and the medical director has to send us an action taken report. This information goes to our board. We've linked the medical directors and the CEO's appraisal to clinical outcomes, something which is really very novel. So this is data that I have from one hospital. This particular month, everything is green, so that's really nice. And this is data from across the group. So you notice that in some months, some hospitals are yellow. One hospital was red in a particular month, then moved to yellow, hopefully moved to green. So it's very visual, it's easy to monitor. Prostrate hypertrophy is a common condition as in males as you age. So what is the average length of stay? If the average length of stay is low, we know that the patient has been managed properly, there have been no complications, no bleeding, and he's able to go home. So the ideal score we want is 4, but you notice that despite the best intentions, when you start off in measuring and you want to focus on outcomes, you go through swings where your outcomes are not where you want them. And then by bringing about change, your outcomes come. For example, in this hospital, about a year later, we had a consistent score of 4, and then again there was a blip, and then it's been fine. Satisfaction with pain, that's something that each one of us dreads when we are going into hospital. Will I have pain? The procedure that will be done to me, how painless will it be? And again, satisfaction with pain goes up and down. We are able to track this. We've also developed the Task 2, which is the Apollo Standards of Clinical Care. So we look at policies, plans, and procedures that each hospital must have within our system. We look at the clinical dashboards. We look at the quality program in how handover happens between doctors and nurses and doctors and nurses. Every single mortality is reviewed, because there are deaths that cannot be prevented, but there are deaths where the death offers a learning opportunity which must be shared. And then, of course, from time to time, incidents happen. Somebody has a fall, or there's an ulcer, or a needle stick injury happens, and we are able to track this through the system that we've developed. So at the end of each month, this is what I get from all our hospitals. It's very visual. We want each of our hospitals to be in the green zone, and the total score that each of the hospitals can a maximum have is 500. So this just gives you a trend of how we've been doing over a period of time. And again, all this would not have been possible without strong IT support. Clinical pathways is something that one hears about a lot. And again, pathways for compliance, we need strong e-presence. So let me just give you an example of a very common procedure, total knee replacement. So we would want our patients to be able to go home in 3 days. So if for our patients to be able to go home in 3 days, well, the surgeon should do a great job. The pain management needs to be appropriate, and physiotherapy needs to commence at the right time, and we don't want any complications. So when you have a system in place that monitors effectively, the compliance improves, and when the compliance improves, you see that the average length of stay in this particular example in one hospital decreased from 4.53 to 3 days, and that means less cost, the patient's able to go home, and the caregivers, and in our culture where a lot of support is available to anyone who's ill, they're able to go back to work earlier. Since 2012, we've been running the busiest solid organ transplant program in the world. We did 1,547 transplants last year, of which 1,077 were done in just one hospital, Delhi. And now about 750 kidney transplants, and the rest were liver. Now, each of these patients is on a host of medications, and especially for the first 3 months, they're on 8 or 9 medications, serious medications in terms of the side effects they have, where a slight tinkering of the dose can result in very severe complications. Now, to be able to manage these patients, we need their blood workup, we need the dosage, we need to have a mechanism in place to be able to monitor them. And we monitor them across 25 countries, because that's where we look after patients from post-transplantation, and that wouldn't be possible without IT. There are some shining examples of what the government has done. eMamta is a very good example. In Gujarat, 85 lakh families, 4.3 crores individuals, being able to track pregnant women, the deliveries, and so on and so forth. And eMamta is a great example of how, at the public level, at the level of a whole state, IT has been helpful. Well, India became a member of IHTSTO in 2014. The central government has asked all the state governments to notify the mandatory use of SNOMED, and I think that will really change things, because it's going to really improve our ability to analytics, which is so important, and to get intelligent alerts, and to also help us in research. The electronic medical record standards, which clearly are a force multiplier in bridging the gap between doctors and patients in remote places. And we have to remember that India is 600,000 villages. And while the government has notified the standards a year and a half ago, one would hope that this really would be embraced by all the stakeholders and soon. So e-health really is the game changer. What can we do? We, I think, need a national information exchange. The National E-Health Authority should have the power to push adoption. Of course, we need to address the privacy and legal framework. Something that none of us learned in medical schools. We learned nothing about IT. We learned nothing about e-health. And I think it's about time that it became part of the curriculum, so that the next generation of doctors, when they go out into the community and when they start practicing, they realize the value of e-health, which many of the senior doctors do not realize even today. And of course, it would help to have a number that can associate all the medical records with that individual throughout his life. So what have we learned at Apollo over the years while we've taken on this task of e-health? We've learned that you have to help each other. There is really no other way. You have to learn from each other, and it doesn't matter whether you're in a small hospital or a big hospital, because quite often the ideas come from the smallest of the small hospitals. And I think if we work together, then of course anything is possible. Thank you very much.
Thanks, Anupam. Interesting presentation. Any questions from Anupam on this?
How much time did your SNOMED implementation take, and so when did you start it, and what is the current state?
Okay, I'm going to ask Karanveer. Karanveer is the guy. He's our chief IT head, and he's going to answer that.
So actually, implementation of SNOMED has been complicated slightly by the fact that the Government of India requires that all statistics are reported to them in ICD-10 format. And although we have got SNOMED running on one of our test servers in Chennai, we haven't actually brought it to the live environment till we sort out this puzzle of how to perfectly code in SNOMED and get data out in ICD-10. So because about 85% of the SNOMED codes do map to ICD-10 one-to-one, but in some there is an algorithm required, manual intervention required, and for that we have to have add-on softwares which are still being designed. But short of that, SNOMED itself is a reality on the server, and we are using it, testing it just to see how it goes.
The reason I asked this question was that we as government have mandated SNOMED. So I think it's important that, just by mandating, we all know that it's not going to happen, because if a group like Apollo is facing challenges for a year plus, believe me, government hospitals would face even more challenges. So I think maybe what we could do, and we can discuss that also separately, is that maybe we could create a body which actually does this homework early enough, even before the NEHA picks up, because it's good to say that, because I implemented CPT and I know that it took me, CPT in Max that was, and it took me almost 6 to 7 months to get doctors to change the procedure codes to CPT, because they are absolutely different codes. And SNOMED is even bigger, right? So the challenge is, I expect anyone to go via, to just implement SNOMED, forget the EHR part of it, is huge. That's the only thing why I thought I'll just take it.
Yeah, Apollo and CDAC are working together to develop this mapping software, and once that is released, then probably the biggest hurdle will be overcome.
Actually, let me just clarify, because as far as the EHR standards are concerned, it is not that all EHR products must necessarily use SNOMED CT. What has been told is that if you are really using clinical terminology, then you follow SNOMED CT. But then SNOMED CT also is a very, very challenging product to use in real life. So our approach has been that, like I told, that we have engaged CDAC Pune as the interim national release center for SNOMED CT. So we have decided basically that we will use SNOMED CT in a gradual manner. Like to start with, we may use it for cervical cancer, oral cancer, such type, because you see SNOMED CT is a very big ocean, and terminology, we really don't have many terminologists in our country. And the SNOMED CT organization, that organization actually is called IHSTSTO, International Health Terminology Standards Development Organization. They are also doing a mapping of SNOMED with ICD-10, and that mapping work is likely to be completed very soon. Earlier they did a mapping of SNOMED with SNOMED CT with ICD-9, then they did it with 9